Hello. Thank you for the opportunity today to present to you on PROMs and adherence. I'm especially going to be focusing on adherence to antiretroviral therapy among adults living with HIV. I'll also be highlighting some of the work that we've been doing in this area. I have no conflicts of interest to declare. So there have been many terms used to characterize patients' deviations from their prescribed treatments. Adherence is meant to connote more of a collaborative relationship between patients and providers relative to some other terms that have been used, for example, compliance. A definition of adherence that I will present today comes from a series of consensus meetings, European consensus meetings, which developed a taxonomy from which this definition has been taken. So adherence here is the process by which patients take their medications as prescribed from initiation to discontinuation. When we look at the rates of suboptimal adherence to antiretroviral therapy that have been reported in meta-analyses, we can see that the rates of less than ideal adherence are quite high, even with simplified regimens, for example, single tablet regimens. So while these percentages here are not necessarily comparable because they use different thresholds to adherence, among other things, it's simply to stress the point that adherence remains a relevant issue. So adherence is important in HIV care and research because essentially it's one of the key determinants of the goals of antiretroviral therapy, which are to obtain and maintain long-term viral suppression and thus help prevent mortality, morbidity, and onward HIV transmission. It's also recommended that adherence be routinely monitored in HIV care. Adherence is a common outcome in HIV clinical trials, and even among the virally suppressed, adherence is worth attending to because adherence is recognized as a dynamic behavior, one that can change over time, and there are still some unknowns about the long-term clinical impacts of for giving newer regimens. So regimens that maintain viral suppression despite missed doses. So there could still be some impacts on viral replication and inflammation, for example. In terms of measurement, measuring adherence, its ultimate goal is to improve HIV care. In this context, in research, it allows us to identify interventions that are worth implementing into care. In practice, it allows us to identify patients who could benefit from adherence support. But there is no gold standard to measure ART adherence, whether in research or care, and there are a wide variety of methods that are used to quantify adherence. These measures have been there's been a distinction drawn between direct and indirect measures, which I will present in the next slides, and each has its own advantages, disadvantages, and specific assumptions. So among the direct measures, we have, well, essentially the definition of a direct measure is a measure that looks at the presence of drug in the individual. So a direct measure would look at drug levels, for example, in plasma, urine, saliva, drug concentrations in hair. And as I said, there are both advantages and disadvantages, which for the purposes of today's presentation, I won't explore. Indirect measures include pill counts, pharmacy refill data, electronic adherence monitoring, HIV RNA. But the indirect measure that interests us most, self-reported adherence to ART, which is a recognized patient-reported outcome measure. It is, in fact, the only measure to directly ask the patient about their adherence, and it's credited as being the most widely used measure of adherence, whether in research or clinical practice. If we look at the review conducted by Marcelin and colleagues of adherence measures used in HIV clinical trials, randomized clinical trials, we see that in 86% of the studies, a self-reported measure of adherence was used, or at least a self-reported measure of adherence. And self-reported adherence measures are actually recommended for routine use among healthcare providers, unlike other measures such as drug use and pill counts and electronic drug monitoring. The advantages of self-reported adherence are its practicality. They're relatively inexpensive, they're easy to implement, they're associated with a low respondent and staff burden, they're flexible, there are many ways of administering these instruments, and they are widely available. So if we look to a recent review that was conducted on identified self-reported adherence measures across different conditions, we see that 25 out of the 121 instruments identified were used in HIV and ART. And these are instruments that had at least some assessment of their measurement properties. So the available pool of self-reported measures used in HIV and ART is in fact greater than that. So there is some evidence of the convergent validity of these instruments. They are significantly associated with other indirect measures such as pill count and electronic drug monitoring. And they are also significantly associated with viral load. So if we look to the review conducted by Simone and colleagues, in 84% of comparisons, self-reported adherence was significantly associated with viral load. But with these measures, there are nevertheless many challenges. So we have the issue of the psychometric quality of these instruments. So in a review conducted by Kwan and colleagues, they looked to see what self-reported adherence measures across different conditions had at least moderate evidence for at least 5 of the Cosman criteria of quality. And what they found was only, well, essentially none of the measures used for HIV or ART that were identified for this review met this criteria. And this includes the very popular ACTG questionnaire of adherence. There are threats to accuracy with these measures, for instance, through a recall bias. Medication taking on a daily basis is something that's quite mundane and uneventful, and this could lead to misremembering. And there's also issues of social desirability bias with these measures, or intentional deception, where scores can be influenced by the beliefs people have about the consequences of self-reporting. So, for instance, an individual could fear being reprimanded by their provider if they report non-adherence. And both recall bias and social desirability bias can contribute to over-reporting and a ceiling effect, which is a positive skew to the scores. We have the challenge also of great heterogeneity in the measures. So these measures differ in terms of their item content, the tasks that are required by the respondents. So some instruments ask participants to provide a global assessment of their adherence, while other instruments might focus more on count-based recall, which is remembering the precise number of doses, for example, that were missed. They vary in terms of the number of items composing the instruments, the recall period, the response format, the administration method, the scoring, and even the cutoffs for defining adherence. So we see the thresholds sometimes or often between 80 and 100%. Then there's the issue of the conceptual complexity of adherence. So there are several dimensions of adherence behavior. There is the actual taking of the medication, so whether or not the individual takes the medication, the timing of that medication, whether the person took a drug holiday, if there was respect of the food restrictions or other special instructions related to the medication. And some have highlighted that few measures distinguish between types of non-adherence. When there's an actual examination of the content of these instruments, investigators have found two main domains. So one domain would be related to the extent of adherence, so the behavior, and the other domain would be related to the reasons for non-adherence, so the barriers or the drivers behind the behavior. And essentially, it seems that a comprehensive assessment of adherence would involve evaluating more than just behavior. Again, related to complexity, we know that there are a wide variety of barriers and reasons for non-adherence. So here we have the World Health Organization's 5 dimensions of adherence in chronic conditions. And so we recognize that there are health system barriers, social, economic, therapy, patient, and condition-related barriers to adherence. And in our own work, we essentially broke down these main domains into about 20 different subdomains. And this framework was developed based on a synthesis of qualitative research with people living with HIV. So essentially, it's meant to represent the barriers that they experience and spontaneously report as affecting their adherence to antiretroviral therapy. We did some further work to examine to what extent current adherence barrier measures covered the concepts within our framework. So we looked at the conceptual coverage of these instruments. So we looked at breadth, so to what extent the measures actually cover each of the large subdomains. So in our model, we have 6 domains, and on average, the instruments contained content on about 4.5 of the domains on over 6. And then when we look at depth, so the extent to which these instruments contained items on the 20 subdomains, the average depth is 7 on 20. And no instrument included content on more than 14 different subdomains. And another element that arose from this research was the observation that there was relatively little representation of barriers associated with the healthcare services and the healthcare system. So for instance, only 6% of instruments had any items on the patient-provider relationship, which arose as being very important in our qualitative synthesis based on the perspectives of people living with HIV. We are not alone in observing this. So in a recent review conducted by Kwan, they distributed the items across the different, the measure items across a number of different categories of reasons for adherence. And what we see again is that the healthcare team and system-related factors domain had the fewest items, and that there's quite a large representation of therapy-related factors and patient-related factors. In another review of generic measures of practical barriers to adherence, none of the instruments captured all 7 of the themes examined by the authors of that review. So another challenge, what I'll call actionability, or the capacity of these barrier measures to actually provide information that's useful for decision making and care. Some barriers may be considered by healthcare providers as beyond their remit. Also, some of the most reported and studied barriers may not be those that are most clinically relevant. So if we look to a review that's conducted by Shubber and colleagues, the 5 most common barriers reported by adults on ART are forgot, travel, busy, change to routine, and asleep. And if we look to a secondary data analysis of 11 ACTG studies, we see that none of these 5 barriers was statistically associated with HIV RNA. So in conclusion, adherence prompts in HIV are definitely convenient. Their choice may be dependent on context, but guidance is available for their selection. They can be further optimized, we know, for example, greater comprehensiveness and perhaps also to address newer concerns. Thank you very much.